Cool, thank you. I just wanted to get the pointer. There's okay, awesome. All right, and then sorry, just getting all my things ready. Okay, afternoon, and welcome back to our Monday academic meetings. Hopefully, yeah, it seems like everyone is really excited. So today I'm going to be talking on HPV because it's causes a huge amount of morbidity and mortality, and it actually can all be prevented by a vaccine, which is pretty incredible. So today I'm going to take us through the current situation in South Africa, HPV infection and its clinical manifestations, our national vaccination program, the new recommendations on kind of prevention and improving prevention, and then lastly, how men are affected. So let's see if this will, oh great, this works. Okay, cool. All right, so we're going to start off with the basics of HPV or human papillomavirus, just to refresh everyone's memories. So it has over 200 subtypes, and genital infections are sexually transmitted, but it's 70 to 90% of these will resolve in within 1 year, which is great. Otherwise, we would have HPV coming out of everywhere. And there are certain subtypes that are high risk. And so these are the subtypes that if they persist, then might progress to an invasive carcinoma. So these are the 12 high-risk HPV types that cause cancer in humans. So HPV 16 and 18 together cause over 71% of all cervical cancer in the world or globally. And then just to note that it's well established that HIV-infected women have a higher prevalence of persistent HPV infection risk. They have a higher risk of progressing to cervical dysplasia, and they have a higher risk of developing cervical cancer. And this is all in comparison to HIV-negative women. Okay, so what's the current situation in South Africa? So the prevalence of high-risk HPV, so that's the prevalence of those 12 subtypes that can cause invasive carcinoma if they persist, is in the range of 37 to 67.7%. And so this figure is based on studies that were done from about 2013 to 2019. The 2017 National Cervical Cancer Prevention and Control Policy, which is quite a mouthful, quotes a prevalence of 54%. And the most common, as expected, the most common subtype of high-risk HPV is 16, and that's followed by 18. But these are the other high-risk types that do occur in South Africa with relative frequency. And so these do need to be kept in mind when we're deciding whether we should be introducing a broader covering vaccination in South Africa. And then of particular concern, the HPV 35, 39, 51, and 59 aren't covered by any available vaccine. And again, just something to note. So I'm going to go through the kind of 4 most recent prevalence studies in South Africa. And these were done, all of the ones that I'm going to be going through were done in women in South Africa. They all have limitations, but they are helpful in terms of guiding with our prevention policies and how we are going to implement our vaccination. So this first study was done in just under 300 women, and they were aged between 16 and 22. All of these women were sexually experienced. They were unvaccinated against HPV. They were all HIV negative, and they were Black women, and they were recruited in Soweto and Cape Town. So their high-risk HPV prevalence was on the higher end. This was 66.7%. Again, HPV was the most prevalent subtype, and this was followed by HPV 58. Sorry, let me go back here. So the authors did note that these participants did have a very high risk sexual practices, and this was based on a survey they did, and that's potentially the reason why this prevalence statistic is so high. So this was the next kind of the third most recent prevalence study, and it was done in 2017. This was done in 280 women, also very young, so 18 to 20 years. They were also all sexually active, and they were recruited from the family planning section or units of primary healthcare systems, so clinics in 4 provinces, so in Gauteng, the Western Cape, Free State, and the Eastern Cape. And they had a high risk HPV prevalence, quite a lot lower than that previous study, and this was just under 38%. So again, HPV 16 was the most common. This was followed by HPV 59, and just to note that HPV 59 isn't covered by any available vaccine at the moment. So all of these subtypes that I've highlighted in pink are the high-risk subtypes that were found in this population. The red bars indicate subtypes that are covered by vaccines that are available. And like I said, 59, and then just down the list, oh, actually I have a pointer, down the list at HPV 39, you can see they're both black bars, and those aren't covered by any vaccines available at the moment. So this is the third study. This was done in 2018 and 2019, so a bit more recent. 280 women, a little bit older than the 2 studies we looked at previously. So their median age was 31. So this was done at a health screening clinic in Soweto, and their prevalence was, their high risk HPV prevalence was 40%. So the HPV 9.3% of this population had HPV 16, and 4% were HPV 18. But most of the women fell into this other high-risk HPV group, and they didn't break this down, so it wasn't very helpful, but still illustrating that 16 and 18 are still the most prevalent subtypes. And then the most recent prevalence study, which I could find, was done in 2019. So this was done in 213 women. So this is quite a young group, kind of like this, or similar to the first study, which included women from the age of 16. So these were mostly 18-year-olds. They were all sexually experienced students who were in grades 8 to 12 in 2 high schools in the Eastern Cape. So their high-risk prevalence was actually very high for, if you think these are a young women, all in high school, but it was, yeah, just under 55%. So interestingly, the most common high-risk subtype here was HPV 59, which I will remind you again is not covered by any currently available vaccine. So again, highlighted in pink are all the high-risk subtypes that were found in this population. The red bars down here are 16 and 18. So these are covered by our bivalent vaccine, which is available or is in the school, the national school program in South Africa. And the yellow bars indicate the vaccines that are covered by the Gardasil 9 or the non-avalent vaccine, which is available in South Africa, but is not available in the state sector for our eligible girls from 9 to 14. Okay, so let's go through, now that we kind of know about the prevalence of our high-risk subtypes, let's go through what the state of cervical cancer is in South Africa, which it's not great. So in 2020, 10,700 women were diagnosed with cervical cancer, and of those, 5,800 had died. So the 2 next statistics are very sobering. It's the second leading cause of cancer in women, and in young women, in our young female population, it's the first most common cancer and cancer death. And it's just crazy to think that we could actually prevent these things. And then obviously, as I've kind of illustrated in up until now, that 16 and 18 are definitely the most common, and 64% of all these cervical cancers in 2020 were attributed to 16 and 18. So how can we try and prevent people progressing to cervical cancer? Obviously, the vaccination, but cervical cancer screening at the moment is also really important. And so what are we doing in South Africa? So the current South African guidelines recommend that women who are low risk get 3 screening tests, whatever they might be, whether it's a pap smear or an HPV DNA screening test. They should be getting 3 tests in their lifetime, and this should be at 10-year intervals. So ideally, you would get your first pap smear or screening test at 30, and then if it was normal, you would get one at 40 years and then 50 years. Obviously, if it's abnormal, you would get a more frequent screening test. And low-risk women are those who are 30 years of age and above. They're HIV negative, or they don't know their HIV status, and they are asymptomatic. So high-risk women are recommended to get 3 yearly screening tests, and it would become yearly if you had an abnormal pap smear, and this is for the remainder of their lives. So a high-risk woman in this context is someone who's asymptomatic, HIV positive, those who have received an organ transplant, those with immunosuppressive diseases, and those who are on immunosuppressive medications. And then lastly, any woman who is symptomatic should be receiving screening at the time of symptoms, and then their follow-up will obviously be based on the result of that screening test. So in terms of the methods of screening, our 2017 cervical cancer prevention and control policy recommends that cytology-based screening, so this is the screening that I think everyone is quite familiar with, via a pap smear, be the method of choice in the short term. So not for much longer. We should be actually progressing to liquid-based cytology, and HPV DNA-based screening should be phased in, and this policy, the 2017 policy, has said that this should be phased in based on resource availability. So the aim is for cytology-based screening and HPV-based screening should constitute 50%. So sorry, the liquid-based should constitute 50%, and the DNA-based should constitute 20% of all screening by the year 2020. And by 2030, we should have liquid-based screening constituting 30%, and HPV-based screening should constitute 60% of all screening. And so we really should be almost all liquid-based and HPV DNA-based screening kind of in the near future. But in 2022, when I inquired about what was happening at SIMJA, they had just started liquid-based screening, and they were intermittently doing HPV screening. And I couldn't find any recent statistics on how many facilities had transitioned. And so if anyone on the call knows, at the end of the presentation, I'd really love to know like how well we're doing in terms of transitioning to these newer and better screening tests. But the fact that SIMJA had not really even transitioned in 2022 doesn't make me very confident that other centers have. So the reason that we're going from cytology-based screening onto these newer methods is that liquid-based screening ensures a much better quality slide, and so therefore it's a lot easier to read. And HPV DNA-based screening has a very high negative predictive value, and the risk of developing a cervical intraepithelial neoplasia stage 3, which is kind of right before you develop cervical cancer. So the risk of developing a CIN3 after having a negative HPV DNA test is almost zero within 10 years. The problem with completely changing to this HPV DNA screening is how we would implement follow-up in South Africa, because we, as I've shown you, we have a high rate of high-risk HPV. So how are we going to then follow up all these women who are found to be infected with high-risk subtypes? And this will likely add a lot of pressure on our primary healthcare system, which is already hugely under pressure and isn't coping. So this is our screening uptake. So we've gone through what we should be offering to women in South Africa, how many women are actually being screened. So this, so overall, our uptake isn't great. It's about 50% or lower. So this image is from a study that used data taken from the NHLS, which reported that between 2013 and 2014, our overall median coverage was 33%. So a third of eligible women had been screened. These were in women over the age of 30. 44 out of 52 districts, so you can see most of this map, were their screening uptake was below 50%, and only 3 districts, you can see in the Western Cape, down there, had at least 70% coverage. So this is slightly updated, or more updated data. It's from 2019, was published in 2022, and you can see here that women eligible women who are low risk. So remember I said that those who are above age 30 should have a pap smear 10 years apart. So 30 years, 40 years, and 50 years. So that population of women in 2019, only 50% had ever received a pap smear in their life. Kind of a broader age range from 25 to 65 were even lower. Only 40% had ever received a pap smear. A screening test, whether it was cytology or pap or HPV based in their lifetime. Okay, so what HPV vaccines are available in South Africa and globally? So there's first the Cervarix, which is the bivalent vaccine, and this is what is a part of our national school-based program, and this protects you against high-risk HPV 16 and 18. There is Gardasil, which is our quadrivalent vaccine. So it protects against 16 and 18, but it includes 2 low-risk HPV subtypes, which cause genital warts. And then there's Gardasil 9, which is our non-avalent vaccine, which includes what the quadrivalent would protect against, but it also includes 5 additional high-risk HPV subtypes. Okay, so in 2014, South Africa implemented this school-based national HPV vaccination program, and this targeted girls who were 9 years and older. So they received the bivalent Cervarix vaccine, and it's a 2-schedule vaccine, and it's given 6 months apart, and it's received within the calendar year. So we started off pretty well. You can see here in 2014, at least 80% of eligible girls received their first dose, and 65% of girls received their second dose. But we drop off from there, and you can see in 2020 that it's almost 0. I think it was 3%. But I'm sure you're all aware, it was during COVID, and this is just another example of how disruptive the pandemic really was. This shows our school-based vaccination program in 2021 and 2022, so post-COVID. And it's definitely recovered, but it's still really not great. In 2022, our eligible girls had only so under 50%, 47% had received 1 dose, and 47 had received 2 doses. So yeah, just not great. We haven't reached pre-pandemic levels, and we definitely aren't reaching what we need to in order to kind of eliminate or prevent a significant amount of cervical cancer. So just to note that this data that I've just presented doesn't include girls who attend private schools, because they don't receive vaccinations as a part of the school-based program. That's only for public schools. There aren't any nationwide estimates on vaccine coverage for the private school sector, but there I did find a cross-sectional Facebook survey which was conducted in 2018, and this showed that under 20%, so it was 19.4%, this was 80 out of 413 girls had received at least 1 dose of vaccination. So these were in private schools. And from what I read, a huge reason for not receiving the vaccine was vaccine hesitancy. And then kind of thereafter was people weren't aware that this is something that they should be doing. But yeah, vaccine hesitation was definitely one of the top reasons. So yeah, so if you do have any girls, if you have daughters in the private sector, please do remember that they are eligible for vaccinations. You would need to kind of go via a private route though to get them. So please just don't forget to get your daughters their vaccines. Okay, so now that we know a little bit more about the current situation in South Africa, I'm going to go on to the kind of new thoughts on the topic. So to start, it's actually really interesting. South Africa is seeing the infection secondary to this high-risk HPV subtype 35, a lot more frequently. And amongst African women, HPV 35 is detected in about 10% of cervical cancer cases in comparison to 2% of worldwide cases. So this study that's on your screen at the moment was done in 2018 and 2022. And this shows the prevalence of high-risk HPV genotypes in 460 women who already have abnormal cervical lesions. So these women were referred to a gynecological department in the Eastern Cape for these abnormal lesions. So this is obviously a very high-risk group. So just concentrate on the blue bars because that's the overall prevalence. So HPV 35 was the second most common subtype just in this population overall, which I said were women with abnormal cervical lesions. In women who had cervical intraepithelial neoplasia type 2, HPV 35 was the third most common. Those with a CIN type 3, HPV 35 was the second most dominant type. And those who were diagnosed with cervical cancer, HPV 35 was the fourth type amongst these women. And so this subtype is highly relevant in our population, and it really needs to be considered for the inclusion in a vaccine, because it's not included in any vaccine at the moment, so that it could be used in our country and obviously other countries where there's a high population of African women. So the next question or thought that we need to consider is, should we be introducing the non-avalent vaccine in South Africa, which is Gardasil 9? So this is the one that covers 7 high-risk HPV subtypes, and then the 2 low-risk genital wart-associated subtypes. So this was a study that did just this. And the reason that this would need to be done is because if we are going to implement it into a national program, the Department of Health, and I suppose the rest of you would need to know whether it is cost effective. The reason why I would want to, or we would want to introduce this vaccine is because it's almost 100% protective against those 5 additional high-risk types, which you saw in the previous slides, South Africa has a very high frequency of. It also protects against about 90% of cervical cancer. It's also, I saw in a recent study, it's also the only way that we would be able to achieve cervical cancer elimination in South Africa. So if we are striving towards that, we would have to introduce this vaccine. So is it cost effective? So this is the study that evaluated whether it would be cost effective, and they compared the bivalent, quadrivalent, and the non-avalent vaccinations in our South African context in girls who were eligible, so 9 to 14 years old. So the incremental cost effectiveness ratio is a summary measure which represents the economic value of an intervention compared with the alternative. So just to orientate you on how a cost effectiveness study determines just this, is that this ratio is, or the ratio is calculated by dividing the difference in total costs by the difference in the chosen measure of health outcome or effect. So in this case, it was the quality adjusted life years, which is equal to one QALY is equal to 1 year of perfect health. So then this would then provide you with the ratio of an extra cost per extra unit of health effect. So this figure shows you the results of the study. So over here is where it compared each vaccine to no vaccine. And in each of these cases, it was quite cost effective to implement each vaccine. So we should definitely have a vaccine in South Africa because that is cost effective. Down in this row, this compares the bivalent vaccine, which is what we have in our national program at the moment, and it compares it to the cost effectiveness of introducing the quadrivalent vaccine or the non-avalent vaccine. So if we introduce the non-avalent vaccine, it would add 0.41 quality adjusted life years, and this would be for an additional 1,700 Rand per person. And sorry, I want to just make sure that I'm getting this correctly. So consequently, yes, at a cost effectiveness, at a willingness to pay threshold of 22,000 Rand per QALY, the South African willingness to pay threshold, the non-avalent vaccination is the preferred strategy, and this is with a probability of 90%. So if you haven't understood anything that I've just said, ultimately the study showed that it would be cost effective for South Africa to introduce this vaccination. The problem is that coming up with the initial money to introduce this introduce this vaccine is often the barrier and is likely to be a barrier. Okay, and then there's this recommendation of whether we should be using 1 dose as opposed to 2 doses in the vaccination schedule. Because as I said, at the moment, it's recommended and is part of our national program that eligible girls get 2 vaccinations or 6 months apart. So in April of 2022, there was the convening of the WHO Strategic Advisory Group of Experts on Immunization. And so that's shortened to SAGE. So they met in 2022 and they evaluated this evidence of whether a single dose is as good or comparable to the 2 dose. And it did seem to be comparable. And so there were these very exciting headlines. And SAGE now actually does recommend that a 1 or 2 dose schedule for the primary target, so those are the girls between 9 and 14 years, and older girls between 15 and 20 years, you can get away with 1 dose. Their recommendation is 1 or 2 doses. 2 doses are still needed though in women above the age of 21, and those women who are immunocompromised, because there is very limited evidence regarding the efficacy of receiving just 1 dose as opposed to 2 doses. Okay, and then I'm briefly just going to go over how HPV affects men. So HPV tends to manifest clinically in men as anogenital warts, which obviously causes a huge amount of morbidity, and it also increases HPV transmission rates. Infections are also associated with penile, anal, and oropharyngeal cancers, which are commonly linked to HPV and HPV 16 specifically. So this was published in late 2023. It is a systematic review and meta-analysis of HPV prevalence amongst men globally. So in order to make this population representative of the general population, the authors excluded any men who were very high risk or very low risk for acquiring HPV. And so what they did is they excluded men who had sex with men, men who were HIV positive, or men who had signs and symptoms of HPV infection. They also excluded any studies that were conducted solely in men who had been circumcised, because circumcision is protective against HPV. And then the other thing to note is that only 9% of the studies included in this review were from low and middle income countries. And so how much it kind of relates to us is kind of, you need to think about that. So the global pooled prevalence of all HPV, so that was high risk and low risk, was 31%. And this was highest amongst men who were 25 to 29 years. The pooled high risk HPV prevalence was 21%. Again, 16 was the most prevalent, followed by these 4 other high risk HPV types. And then the pooled prevalence for any HPV was highest in the sub-Saharan African region, and that was for 37% for all HPV, and for high risk it was 25%. And then I just thought it was interesting that HPV 35 is the 5th most common high-risk subtype, and so this is occurring in men as well as women. I just thought that was interesting. I just wanted to bring your attention to that. So men who have sex with men and men who are HIV positive are at a much higher risk of developing HPV infection. And the risk of developing invasive anal cancer is 17 times higher in men who have sex with men compared to men who have sex with women. And this risk is doubled in patients, men who have HIV. So a study in 2015, which was done in the Western Cape, supported this by showing that HIV negative men had a prevalence of HPV, all HPV of 50%, whereas men who were HIV positive had a much higher prevalence rate at 76%. The authors do say, though, that all the participants in the study volunteered, and so it may not be representative of the general population and might be the reason for such a high statistic. So in a study that was done in 2016, it was also done in the Western Cape, and this was done in men who had sex with men. They had an overall or median age of 32. They had an overall prevalence of 75%. Again, a very high prevalence rate. So 57.6% had high-risk HPV at the anal site specifically, and 7.5% had oropharyngeal high-risk HPV specifically. The 6% value comes from a study done in Pretoria, also in men who have sex with men, and that was in 2021. So this data shows and supports that sexually active men are a really important and big reservoir for HPV genital infection. So because they're such a reservoir for infection, I think that preventing HPV in men is going to assist in cervical HPV and cervical cancer, but obviously we want to assist men in their significant mortality and morbidity. So the 3 ways in preventing HPV in men would be condoms for the first one. So there was a 2-fold risk, lower risk of developing HPV in men who had no steady partner but used condoms, who always used condoms, which supports this intervention. There were 2 randomized controlled trials which were done in Africa that showed strong evidence that medical male circumcision is protective against HPV infection. And it also showed that it reduced high-risk HPV infection or transmission to female partners in HIV-negative men. So that is a really important intervention that I think is quite possible. And then obviously vaccination would be the best preventative measure, and it has actually been shown to be highly effective in men. But it is unlikely, because it's unlikely to that the men who have sex with men population would benefit from the herd immunity created by our female vaccination rollout. It would be really optimal to vaccinate men when they were boys, or so from the beginning. There are unfortunately no plans to include boys in our national vaccination rollout program. So in coming to the end of my presentation, I wanted to emphasize some points for you to kind of consider and take home and think about. So please do remember that HPV and its sequelae can cause a huge amount of morbidity, and it obviously causes a huge amount of mortality, and it's something that we really can prevent. We really need to be moving towards DNA-based screening tests much more quickly than we are, but there is going to be a knock-on effect in terms of follow-up of patients who are found to be high-risk HPV infected, and so that is something to think about. Our eligible girls currently do have access to a highly effective vaccine, the Cervarix vaccine, but it doesn't protect against frequent high-risk HPV subtypes that are found in our population. And so it really seems like we should be introducing Gardasil 9 or the non-avalent vaccine, especially because it's been shown to be cost-effective. And because our coverage of vaccination really isn't great, I mean, it's less than 50% in 2022, should we be moving towards a one-dose vaccination schedule? I think that this is actually really difficult because our population does have a very high prevalence of or high burden of HIV. So would we then be underdosing a high proportion of HIV undiagnosed women? If they were known to be HIV positive, would they then have to disclose this and at school in order to receive their second dose? And how are we going to ensure that immunocompromised women do receive their second dose? And so these are all things to think about. And then lastly, I think we really do need to pay more attention to HPV infection in men. And I personally think that a good place to start would be to increase our screening practices in high-risk men. So men who are HIV positive and men who have sex with men. This is obviously in addition to encouraging condom use and encouraging our male medical circumcision. So yeah, thank you so much. I hope that I enlightened you a little bit, and if not, maybe to think about some new things that you maybe hadn't thought about before.
Thank you. Really, really, really awesome. Lots of questions coming up, so I hope you've got your you braced. So let's start maybe with a question from Nasisa asking about the age of starting screening. So I guess according to DOH regulations, at least for now.
Yeah, so low risk, start screening at age 30. High risk, which is HIV positive, immunocompromising in medication, there we go, that's every 3 years. So I mean, I think obviously you have to be sexually experienced. So if you haven't had your sexual debut, you haven't had sex before, then you don't need to screen. So as soon as you're sexually active, then if you're high risk, start screening then, and then at every 3 years. Low risk, start at 30.
Cool, thank you. And I should just add, I mean, there's people, you know, in the audience who from Department of Health, etc. For example, if you want to add anything, just raise your hand. We'll unmute you. There's a question about screening MSM patients, asking what the recommendations are. You did kind of allude to it a little bit at the end, just because Evan's making the point, it's usually too late by the time they get to the surgeons.
Yeah. So there aren't any South African guidelines, but sorry, I actually don't know. I didn't look at the international guidelines, but I mean, I would think that it would be similar, I suppose, like high risk men, so MSM who had sexual debut, they should be getting screening probably every 3 years. I think it's kind of our high risk. So HIV positive men and MSMs should be getting 3 yearly screenings. I'm sorry, I don't actually know the actual guidelines, but I agree that. But I think that that's one of our problems as well. Like as doctors, I mean, how many times have you ever thought about referring a man for HPV screening? And so I think that's just making more people aware of it would really help. But yeah, you're right. It is usually too late.
Yeah, agreed. It's just looking up at the US guidelines for what it's worth. I mean, obviously,
Yes.
not necessarily extrapolatable here. You're right. I mean, I don't think we have any policy at all for MSM in South Africa. They're recommending adults 35 years and older who have HIV and are MSM, transgender women or transgender men, perform annual pap smear testing, actually.
Sure, that's a lot. Yeah. Wow, okay.
But I mean, obviously, that's in the context of different resources and, maybe very different. So just looking through, Jeannie's making the point that Australia vaccinated boys and girls and have virtually eliminated HPV and cervical cancer.
Yeah, I mean, it's amazing, high resource setting. If you get vaccination right in girls, that herd immunity, like kind of very quickly affects and benefits men. If you can then obviously get your men vaccinated as well, you then are going to be protecting men who have sex with men. So, I mean, I think at the moment we need to concentrate on our girls, and when we get that right, and maybe if we have more resources, then we can go with boys. I think if we had all the resources in the world, I would include everyone. I think a gender neutral vaccination would be definitely the best thing, but our resources aren't great.
Yeah, agreed. And Australia were the first, I think, weren't they? The first of the at least Western countries to roll it out. So they have the best data. Yes. Just looking through some of the questions. Any data on the HPV types found in young children with perineal HPV lesions? Narcissa is saying we see a lot of HIV young children, like less than 5 years, with perineal warts.
Gosh, Narcissa, I have no idea. I didn't come across anything with children. But is that like vertically transmitted? I have no idea. I'm just, how are you saying that they acquire it vertically?
Yeah, I mean, my guess would be that way, in which case they'd presumably mirror the mom.
Yeah, that would make sense.
But I don't know. Talia, you've got your hand up. You're welcome to unmute.
Hi guys. Thanks for an awesome talk, Lauren. At Emplueni, we're actually trying to increase our HPV screening, and sorry, I can hear my voice echo in the other room. We're trying to increase our HPV screening, and we're trying to actually do a bit of a survey on the vaccination uptake from our girls or adolescents who are living with HIV. Just to kind of give you a little bit of info, you were asking about the liquid-based screening.
Yes.
Obviously, at Rahima, we're seeing all the gynae patients and we're doing pap smears. All of our screening at the moment is liquid-based, so we're not really using slides anymore, which is really great. But in terms of the HPV-based testing, again, it's still very intermittent. On all of our pap smears, we are requesting high-risk HPV screening, but it comes out sometimes and then other times it doesn't. So I think it's really related to when studies are being done and not. And then in terms of vaccination, what I wanted to ask is, did you come across any studies suggesting that immunocompromised patients should receive 3 doses of the HPV vaccine? Because I know that the CDC guidelines at the moment are saying that if you're immunocompromised, you should technically be receiving 3 doses.
Thank you so much for telling me about the liquid-based cytology. That's really exciting. I'm so glad that at least, tertiary centers have moved on to that. Yes, so I haven't found any more recent evidence saying that HIV positive or immunocompromised patients are okay to get 2. So again, we're going on those recommendations where they say 3 is ideal, and if you don't have the resources for 3, then at least 2. But no, I don't, unfortunately, I didn't come across anything kind of with recent data behind it, but I also didn't look super hard, so there might be data out there.
Okay, thanks. Yeah, so just because we've been looking at this, it's really just more because now we're currently running a high-risk clinic at Rahima for our gynae patients and ANC patients who are not virally suppressed. And they have been following up at our clinic for ARVs as well. So we've been trying to make sure that everybody is screened and everybody has a pap smear. And I've just kind of looked at the numbers out of a research context, but essentially been recording, and we are seeing that essentially more than 50% of our patients have an abnormal pap smear result. And then if you want to further divide it, about half of those, so about 25%, have a high grade lesion or atypical cells with high grade suspicion, and then about 25% are having a low grade lesion. So it's quite scary. Even more than 50% have an abnormal result, but those are obviously the 2 categories that we need to consider sending for colposcopy. And then in terms of the vaccine,
sorry, Talia, that's the age group, that these are all like below 18.
No. So I've actually looked at both groups. So the ones I've just told you about are actually our adult patients.
Oh, sorry.
So those are adult patients. So either caregivers of children living with HIV or otherwise high-risk ANC or high-risk gynae patients. More than 50% have an abnormal pap result. And then in our kids or our adolescents, we start screening them when they've been screening in terms of a pap smear when they've been sexually active for 1 year. Also trying to make sure that everybody just knows that they need to get pap smears done once they leave our clinic and kind of graduate to adult care. And so far on our children, we haven't found high-risk lesions, but we have found high-risk HPV subtypes. And we've also found about, I think, 25% of patients having a low-grade lesion. So most of those patients, when we've looked at them as well, have not completed their HPV vaccination schedule. And it's also less than 50% of our clinic who are the HIV positive population who have actually received an HPV vaccine, which is scary because they don't have access to it again outside of the grade 5 school vaccination campaign, essentially. So we're trying to actually see if we can motivate to get that vaccine in clinics where there's at least a high-risk population.
Cool. Thanks very much. That's very helpful to know.
Thanks.
Rispa's asking about people who've already had Severix or Gardasil 4. What do you do about the other 5 in Gardasil 9, for example? Can you revaccinate them, or what's the recommendation?
Yeah, you definitely can. So they've got up to 10 years, I think, of kind of the duration, or you are protected by your vaccine up until at least 10 years. We just don't have data beyond then. So people actually do recommend revaccinating to ensure that your protection is maintained or your antibody response is maintained. And so it's very easy. You just basically give them the Gardasil 9. I mean, yeah, in terms of a kind of cost effectiveness, in terms of revaccinating people, I'm not sure that would be cost effective. But if you are a private patient and you've received Cervarix or Gardasil 4 and you can afford it, or get it on your medical aid, then you should get your Gardasil 9. The other thing is, obviously, it even if you have been sexually active, if you then get your vaccine, you are going to then be protecting yourself in the future, and so it's not it's still beneficial.
Cool. And then there's a couple of questions. I'm just going to cluster a few of them together. Asking about the mechanics, well, not the mechanics, but the details about screening for HPV in men. So, for example, not the frequency, but how do you do it? What do you do, and what methods would be recommended?
So it's very similar. So at the anal sites, you again will and you've got to insert your kind of brush or yeah, kind of a brush. I don't know if you would use a spatula, but probably a brush. You've got to insert it. I think it's like 3 centimeters. You've got to go kind of you want to be reaching the transitional zone, and you then have to rotate it. I think it's 3 times, and then again, then you pull it, like take it out and put it into the liquid medium. The penile or yeah, so the penile samples, they either use a swab or urine, but the sensitivity and specificity for that is not as great as like anal sampling and orogenital sampling. The orogenital sampling, again, that you can do like a kind of a spit or a gargle, like you I'm not actually sure if you use water or saline, but you basically put some kind of liquid in your mouth and you kind of gargle it and swish it around, and that gets sent off for HPV. You can also pretty sure you can swab the your oropharynx. Not 100% sure about that, but yeah, those are the kind of the 3 ways in which people are currently testing for HPV in men. Hopefully I answered the question.
Yeah, that's great. I see that. Yeah. So obviously there is anoscopy too, like, sort of analog of colposcopy, I guess, but that's not widely available. Well, it's not available at all in the state, but in theory it could be. And then, yeah, liquid-based mostly. There's obviously no direct pap smear equivalent, but liquid-based and obviously PCR ideally, right? I mean,
Yeah.
as you said, it's very, very similar. It's just a case of access in the state, which is not, really, there's no policy around that at the moment. And obviously the cost effectiveness would need to be worked out in the private sector. There's just less awareness of it, maybe. So, the resources exist, but just less commonly done. Because I see Gail's asked there about, how to actually sample them in. Yeah, because she's saying also urology and colorectal have advised the patients need to be seen at specialist services. So yeah, it's very difficult because there's no good system at the moment.
Yeah, I'm not sure if you can use, if it's a different brush or like instrument. I'm not actually sure if you could just use a.
I think you can, but maybe someone in the audience may know.
Yeah. I mean, that would be great. Sorry, yeah, someone who actually.
For the liquid that we're talking about, obviously, not the slides, but yeah.
No, yeah. How to like obtain sample.
And then, with some of those vaccines where there's multiple serotypes, and I mean, it's not quite the same as serotypes, but you sometimes with vaccination get serotype replacement, like you do with HPV. Sorry, beg your pardon, with pneumococcus, for example, at least in some countries. Is that in the literature here about that with HPV? Are we, for example, if you do a lot of 16, 18, do you just shift the burden to other ones? I'm not talking proportionally. I mean, like absolute terms. Like, for example, do the others increase in proportion because they have a sort of an advantage?
I haven't read any of that. I'm not sure. There's like sorry, I thought what you were going to say, but there's some kind of evidence that there might be cross protection with some subtypes, but kind of not enough to say that like if you've been vaccinated with one vaccine, then you have cross protection for other high risk subtypes. But no, I'm sorry, I don't actually know. I think most of the places who have that kind of level of data have they've started like vaccinating men, and and then you kind of almost got rid of it, and so like all HPV, and so I'm not 100% sure. I'm not sure at all, actually.
Yeah, no, sure. I see Jeannie Elliott put in the chat same sample.
Okay, great. Same sample brush. Cool.
Okay, I'm just looking through. I think we've got most of them. Sorry, some I had to combine the questions because there were lots of questions which came through. I have put the link in the chat for CPD points. I will just put it in the bottom of the chat now, just so everyone's got it's right in the front, but it's up in the chat otherwise. Let me just copy it again. All right, so I've pasted it there. So if you click on that and enter details, you should be able to get the CPD points. We batch them once a month, so they should come through next month if the HPV.
I just wanted to answer. Eunice asked what samples are used when doing HPV screening studies, especially in men. So it was exactly that. It was kind of anal specimens, and then penile they used urine, and then oropharyngeal was either like kind of a spit or a swish and spit, or oropharyngeals like kind of swabs. Just want to see if there's anything else I can answer. No.
And then so Cabella's asking about specific, Gauteng circular. So we don't unfortunately talk on behalf of the DOH, I'm afraid. So I'm not sure, but I'd imagine that is the policy of 1 dose rather than 2 for the schools. Okay, I think that's it. So thank you very, very much. There's a really nice turnout and loads of questions, which you handled really well. So thank you very much. Nice update and lovely to be up to date with some of the latest stuff.